I think your focus for today should be those who are especially doing the hands-on. Whatever you know, whatever you've learned from yesterday, just try to consolidate those things. Or if there are areas that you're still not comfortable with, still not happy with, just try to practice those. And if you've got any doubts in your mind that this doesn't work for me, ask, clarify. Remember, there are two systems. There's an ME2 and ME3 system, and then there's another system, which is the Arietta system with the Fuji scopes and room Endo 1, which is much better system compared to the ME2 system. So ME2 system, the images are not very good. I think the images, I don't tend to like ME system or the images, because if you look at the images are very granular. They're not as crystal clear. So if you worked in ME2 or ME3 room and also in Endo 1, isn't it? And diffuse. So if you look at, there's a huge difference. Slight problem is that the Arietta scope is a bit away from you. So in your own setup, what you should do is you should try to arrange it such that the whole system, the panel is on your right here. So in our system, we've got the patient's head. That's how we are scoping, and then the whole Arietta system is right in front of us. So we can change the images, we can change the harmonics, we can change whatever we want to. So So it's very important. आज आपका task ये होना चाहिए. In your head, just break it down. What is not working for me? Where do I find it difficult? How can I get over that hurdle? ठीक है? And whatever the answer you get, just try to find कि जी मैंने ये करना है, ये करना है. This is what I'm going to focus on. Not too many things. If you try to do too many things, you'll get confused. जैसे मैंने कल कहा था, there are 4 things in EUS learning, in my opinion. One of them is a scope handling, and those who do ERCP, they should not have any problem doing in EUS. That's number 1. Number 2 is all about pathology management. So if you've been to tumor boards or MDT and you've got a background knowledge, you've done your exams, FCPS, so you know that already. So that shouldn't be a problem. Third thing is anatomy, basic anatomy. We all know basic anatomy, so that again should not be a major hurdle. Important thing to realize there is, what are the variations of anatomy? Where do I need to know how is that alteration or change in the clinical anatomy relevant? And for example, one of the things is like, pancreatic cancer is replaced right hepatic artery. So what is the relevance of replaced right hepatic artery? And does it actually matter if I'm able to identify it on EUS or not? So all those things, and the last and most important thing in my opinion is all about image optimization. All about image optimization. And those who are good at optimizing image, Asjad, please play. And those who are, that's okay, don't worry. Got it. That's fine, got it. It's fine. All sorted. Okay. So, with your permission, shall I make a start? You should? Okay. Or you can open the day 2 officially, and then we can. Okay. So it's just the ES liver anatomy. No, I think it's just that, I mean, you can if you want to, but in terms of yeah, okay, let's go for it.
Testing? Okay. Testing. Assalamu alaikum, everyone. So we'll be starting off our program for the day, and it will be a talk by Dr. Nadeem Tehami on EUS liver and their anatomical landmarks. So everybody please give a round of applause for Dr. Nadeem.
So are you okay? So that's what we're going to discuss in the next sort of 15-20 minutes. Why are we discussing this? I think that's probably the most important thing. But before we get to it, let me just talk through what I was trying to allude earlier on. So there are a few things that you want to have in your mind, basic things, based on what we learned yesterday from Dr. Mustafa Ryan's talk. And that is all about image optimization, which I believe is the most important pillar of EUS learning. Because if you are able to produce a good image, you'll be a lot more comfortable. So I'll share my personal anxiety with you. So when I go to any other unit, including here, If you go to a unit and you start looking at an image and you've not optimized that image, it's a problem. If you can't optimize an image, you won't be able to appreciate anatomy, normal anatomy, and abnormal anatomy. So, image optimization, in my opinion, is the key. In our setup or whatever setup you have, what you should do is you should have some presets. So, you should have a preset for liver, preset for pancreas. That's what we have in our practice. Or you can have a preset for upper GI, or you can have a preset for HPP endoscopy. Preset is your optimum depth, optimum gain, and based on that, you can have a preset. Advantage is if you start looking at image and for some reason you can't produce the image that you want, you can go back to your preset as if you are doing starting your examination and you've seen the celiac axis take off. And if you then get lost, what you want to do is you want to go back to the base station, isn't it? So you've lost and say, oh my God, let me start again. You want to go back to your base camp or base station. Likewise, the presets gives you that advantage that you were trying to optimize image, you were changing the depth, you're changing the gain, and suddenly image has become blurry and you can't actually figure out. So you can go back. So this was my preset for liver, this was my preset for pancreas. So you can fall back. Another important thing, obviously, as we discussed yesterday, is the enemy of ultrasound. Therefore, throughout this examination, we want to maintain good coupling. Good coupling, less air. In some situations, however, you may have to introduce water, especially if you're in D2. Because again, the case we had yesterday, if you're not using balloon and you're trying to shorten the scope with the tip up, there's always a risk. The moment you try to relax, you just can't keep dragging the scope back. All you're doing is bringing the scope few folds together. And then you can end up misinterpreting temporary pathologies. What we've done is we've just dragged too many folds together in order because we were scared of falling back, that certainly we have actually completely ruined our chances of picking up a pathology. And the moment we just try to straighten it, we fall back. So therefore, you may want to stay there, put some water in, making sure, especially if the patient's tubed, to improve your coupling. Gain, brightness, single the time gain compensation. As again, when we started in your case, Junaid, yesterday, we went into the room, we saw that the frequency was set at low, we increased it, we saw that the time gain compensation was all over the place. Somebody will come and clean your panel and it's all disturbed. So you want to go back to your base cam, you want to therefore have it set up. Few things, it's like moving on from driving manual car to an automatic car. You don't actually have to think about changing the gear. Your car does it automatically. The old cars, full of buttons. New electric cars, you hardly find a button. You hardly see a press. Where am I going to press? Because machine does it for you. Likewise, newer machines have few things. Focal length, you don't actually have to worry about. Focal length, you'll see a pointer right at the side of the screen. What it does, it just basically concentrates your energy or focal length at a point where you actually examining or your point of interest. But with the newer machines, it just happens automatically. And one last thing, I think, which is probably very important, 2D images, static images. If you can record videos or loops, if you are in your tumor board in UMDT, you can replay those and produce it. But if you're just taking static images, what you want to do is you want to take images and then you want to annotate those images. For the benefit of records, for the benefit of documentation, it's a medical record, it's a legal document at the end of the day. So that it makes sense, whoever then looks at the images, they may or may not be there. They may just be seeing as a static image, not knowing where the probe is. So one of the things we tend to do is, where the probe is, I tend to write down their stomach or D1 or D2. So what it tells whoever looks at the images, that this is when the probe was in the stomach, or this is when the probe was in D1, or this is when my image is top stomach D1, especially if it's a very relevant. If you're taking 100 images, you won't be able to do it. But if there's a pathology or one critical image, once you've done where the probe is, then you can just sort of highlight the pathology, or if there's something that's important for you. As I mentioned, if it's a case you've seen earlier, replaced right hepatic artery, this patient that decision may have consequences for the surgeon. You want to then highlight it, that this patient has a replaced right hepatic artery and that's where it is. So that's how it helps you in getting there. So I thought it was important for us to sort of discuss it. And now we will then talk about, so why are we actually talking about liver anatomy? I mean, Traditionally, the teaching have been through those station-based approach or your base camp, and we have an approach of looking at the left lobe of the liver and then going to the aorta and then identifying the organs there. But why are we not focusing so much on the liver? Why do we want to identify the segments of the liver, what the vascular anatomy is, what the relationships are, what is the relevance? I guess. Yeah, absolutely. No, you're very right. So, what has actually happened over the last few years, at least in the last 10 years, number of areas in the liver medicine where EUS has actually revolutionized the practice. There were things that we were doing previously. We were only dependent on one modality or the other. If there's a patient with a caudate lobe lesion, which cannot be safely sampled through percutaneous approach, where you cannot actually do a microwave ablation or an RFA through the percutaneous approach, what are we going to do? With the EUS availability and advances in the innovations and the therapies, we now are able to safely biopsy, and in cases be able to do radiofrequency ablation, even for the hepatomas, which were previously not possible. That's just one example. There are a number of areas where EUS has actually revolutionized this practice. There are certain areas where we don't have enough evidence, and this is a process of sort of evolution, and more and more with the more time we're gaining more evidence. But that's why it is important to study liver in more details, especially if it's related clinically. Something very basic. So there are two things in liver we're looking at. We're looking at a parenchyma, and we're looking at the vessels inside the liver. Okay. One of the commonest problem all over the world is fatty liver disease, steatosis. So purely by just looking at the liver parenchyma and the vasculature, we can do a subjective assessment. We can two things looking at it: vessel, their caliber, how uniform it is, and how thick or prominent the walls are. So if vessels all looks uniform throughout the liver, and the vessels walls have that distinct hyperechogenicity, and the lumen remains uniform, it's not unlikely to have a significant steatosis. Going to the severe stage where the uniformity is lost and you can't actually make out the hyperechoic wall. So that's just one example. Purely by looking at liver, you can determine how significant the steatosis is, which is obviously significant in some patients than the other. Then looking at the vessel walls, not just sort of relying on those two things, we know we can do this pulsed wave Doppler. From the medical school teaching, we all know those ACV waves. We know the triphasic normal waveforms in the hepatic veins. Okay, and then the flow. We know the velocity in the portal vein is directly determinant of the portal hypertension. We know that is determinant of the patient's risk of developing portal vein thrombosis down the line. So purely by looking at the waveform Doppler, if that triphasic waveform is diminished or lost, that can give you an idea that this patient may have an underlying portal hypertension. So I won't go into detail of it, but this should just give you a bit of a broad idea why looking at the vessels, why looking at a Doppler waveform can actually help not only answering the steatosis, but also based on the underlying portal hypertension. There was this nice, I think, a poster in DDW about 2 years ago where they just injected a contrast and measured the time from the time it was injected to the time it appears in the hepatic veins. And if the time lag was more than 14 seconds, it was a predictor of underlying portal hypertension. So simple things like just injecting a contrast and waiting for the time it appears. So much information. There's another utility of doing elastography. We do a lot of fibroscan in the liver medicine, which may not be possible in somebody who's very obese. How are you going to do that? And sometimes there's an anatomical variation. A normal person may have a liver which is kind of high up in the liver, and you're only just scanning the ribs. you're not actually be able to access to a proper fibroscan. So this is where the elastography comes in. Again, I'm not going to go in detail of it. This should give you a broad idea. You know about the strain elastography, which is essentially just looking at the compression, the effect, the waveform, that your resistance that you get in return, and then the shear wave, where it's like a propagation of the waves, and then the software determines how smoothly those waves are traversing through the tissue, and based on this we can decide. So shear wave and the strain wave. Most all machines have strain wave. New machines have a shear wave elastography. Just one thing to remember from this slide. As far as the strain elastography, the old technique is concerned, it still has a utility if we are looking at a focal lesion. Whereas the shear wave is definitely what you need for parenchymal liver assessment. So strain wave for focal lesions, shear wave for the parenchyma. That's probably just one thing for you to take away from this. So this hopefully should gives you how relevant assessment is. Okay, now we're coming to the liver anatomy. I guess you all know why and how the liver anatomy is. We discussed. Did we discuss the liver segments yesterday in the room or not? But obviously, I guess you all know. You know the right and the left lobe. You know the differentiation of liver segments. The important thing to remember from this slide, again, one is that the portal vein branches and the hepatic veins, as you see on the screen, they transect each other in a perpendicular plane. So that's a key concept to take away. Because they're transecting each other in a bit of a perpendicular plane, what you will see is when we're actually doing an EUS examination, if you're seeing a perpendicular complete length of a hepatic vein, the portal vein not going to appear in the same direction. You're going to have just perpendiculars completely. Only you're going to see a section of the portal vein. So there, or if you're seeing the portal vein in a complete length, you're not going to see the hepatic vein because they're actually perpendicular to each other. Make sense? Yeah. So important thing to bear in mind. The other thing is, as far as the hepatic vein branches are concerned, they divide. So segment I'll show you on the images is the middle hepatic vein, right hepatic vein, left hepatic vein. It just if the portal vein branches are dividing liver into sort of superior and inferior, the hepatic vein branches are dividing into the right and left liver. So simple things like this. And what it does in terms of the segmentation. So middle hepatic vein, left hepatic vein, and then the right hepatic vein. So from segment 2 and 3, and then the left liver, and then the right liver. So medial, anterior and posterior, medial, lateral. That's kind of the differentiation that you get by looking at these veins. So that picture just sort of tells you that these are veins at sort of perpendicular to each other. So far, okay? Happy with that? So 2 hemilivers, 8 segments, 2 approaches essentially. Okay, just for the benefit of sort of discussion here, we are going to say that left lobe we are examining from the stomach, transgastric, and then the right lobe we're examining from duodenum. You can still look at a bit of the left lobe even from the duodenum, but just for the sake of discussion here in our practice here, stomach, we're looking at the left lobe, duodenum, we're looking at the right lobe. Okay. Some key landmarks, again during the assessment, is portal vein and the hepatic veins. IVC is going to be your starting point, but from then onwards, just the portal vein and the hepatic veins. Some ligaments, which again helps in demarcating the segments of the liver, ligamentum venosum and ligamentum teres. And then you can look at some structures. So as Dr. Hassan yesterday said, if you're in the duodenum and you're looking at the kidney, you're just next to the liver, segment 6. So things like that. So if you look at the gallbladder, which segment is going to be next to the gallbladder? Segment 4, you're looking at the right kidney, you're looking at the segment 6. So association in terms of those organs. So this is kind of just a broad line. Having said this, it's really important that there's no strict demarcation. When the probe is moving, there's a lot of overlap. It's a 2-dimensional imaging modality. It's not 3-dimensional. That's number one. There's a lot of overlap. There are a lot of different planes. You start with examining just be the GOJ, and then as far as you're advancing, you are progressing from one area of examining to the another area. Therefore, the plane may change. When the plane change, the orientation is going to change. And that can cause a bit of confusion depending on the patient's body habitus, depending on the machine, depending on your presets, all those things, and depending on the underlying disease, if you're doing a patient under enhanced sedation or conscious sedation. Now, I think, Asma, this morning, there's this nice recent paper, I think, published in GIE. In fact, good video in GIE only come in, I think, last week. Really nice video. So it's a free access video from Radhika Chavan. So if you go through it, you should be able to see this video. But the importance is, I think, from this image, as far as you see, so the two things, when I'm talking about the plane, so as soon as the scope goes in from just below the GOJ, and as you advance, your scanning plane also changes. There are two ways if you can do it. You can either start orientating yourself by looking at the CT images and then doing EUS images, or you can just keep it very simple and based it on the pattern recognition. Okay. Which then actually initially helps you to orientate and develop more confidence. Okay, once you've done that pattern recognition, a few months, years down the line, you can then just try to see if, am I doing something wrong? Or you can then obviously start orientating yourself based on the cross-sectional imaging and see if that then makes sense to your practice or not. So we'll just try to keep it very simple. So the first thing, again, I hope you all remember yesterday, as soon as we've gone past the GOJ, gastroesophageal junction, insufflating an air, advancing it toward the greater curve of the stomach. As soon as we hit there, we start to take the air out. We try to suck all the air out, and we should find ourselves landing on the left lobe of the liver. Now, majority of the time, because we're doing a pancreatobiliary cases, what I tend to do, is this is kind of more of a personal approach. I try to advance the scope and personally, once the scope is in this position, and if I'm seeing the left lobe of the liver, as Dr. Hassan said yesterday, you want to see 2/3 on the one side of the right side of the screen and the 1/3 on the left side of the screen. As soon as you advance, I tend to advance this scope at that stage so that I can see the tip of the left lobe of the liver. In my mind, it helps me in two ways. One, if there's any perihepatic ascites, especially in the cancer cases where you're trying to do the staging assessment, it helps you. And also, if any complication happens as a result of the procedure, I have documented already whether there was ascites or air pre-procedure. Air, you obviously not going to find any fluid there or not. So pre-procedure, base camp, presence of ascites helps in two ways. Staging, ascites small amount, perihepatic can easily be missed, which can then help you in kind of contributing to the staging of the disease. And then you basically come back to stage where you were and you want to see the left lobe, which majority of the cases you will be able to do this. So make a habit, the one thing at least in the liver that you should be doing in every examination or trying to see in examination is this area, which is the left lobe, looking at the hepatic vein going away from you toward the tip of the liver. And then you can see the segment 2, which is closer to the probe, and segment 3, which is away from it. Okay, so this is something which most of the time you should be able to appreciate. And then the more you do it in practice, when you actually need to do the therapy, it will become a lot easier. Because remember, with the pathology, it alters the anatomy. And it's not as easy in saying, oh, this is definitely the hepatic vein, and this is the segment 2, or this is segment 3. Remember all the changes that comes into the liver. You lose the vessel wall, you lose the lumen of the vessel. So that uniform hepatic vein is not going to be obvious, especially if it's a disease segment. So segment 2, segment 3, segment 2 closer, segment 3 above. Advantage obviously here is liver biopsy, lesional biopsy, medical biopsy, antegrade stenting, and hepatogastrostomy. Okay, so something we can do that. And at this stage, if we are able to, so I think most of the time, if we, and at least in sort of 7 out of 10 cases, you should be able to see the left hepatic vein in that neutral position with the suction with the tip up. And as we advance, that we start to rotate. So from the left hepatic vein to the middle hepatic vein, and from the middle hepatic vein to the right hepatic vein. Not going to happen in every case. You may have to sort of withdraw the scope ever so slightly, coming back to the intrahepatic portion of the IVC, but in at least, again, 6, 7 out of 10 cases, you should be able to see left hepatic vein, middle hepatic vein, and the right hepatic vein, literally by doing this. So when we sort of, from the left hepatic vein, as soon as we sort of advance, start to do a clockwise talk, you should land, or you should start to see this big fish eye or fish mouth appearance, which is the umbilicated portion of the portal vein. And then this, like, the very echo bright strand that you see going from umbilicated portion of the portal vein into the IVC is ligamentum venosum, and then the other side is ligamentum teres. How it helps? It helps us in differentiating segments. So segment 1, segment 4A, 4B, and 3. So segment 3, which was before underneath the hepatic vein, left hepatic vein, has now come up. Okay, so that segment 2, hepatic vein, segment 2 and segment 3, the moment we start to rotate, now segment 3 has come up. 1, 4A, 4B, and segment 4, 3. So easier. Now, again, advantage at this stage is because this is mostly the site where we want to do the portal pressure measurement. Very easy to access, doesn't cause any massive problems, easy to puncture without any massive problems. So, good site to do the portal pressure measurement. Still staying in the stomach. As we sort of further try to rotate, you will start to lose segment 1. But then in the same plane, when you're seeing ligamentum venosum, the vessel that you see is usually the middle hepatic vein. Okay, it's unlikely to see the right hepatic vein with ligamentum venosum. That's number 1. Number 2, middle hepatic vein usually has a very uniform caliber, starting from coming out from the IVC, going all across. Now, so we've got segment 1, 4A, and segment 8 underneath. If you then continue to...
So if you look at the portal vein and then you look at the hepatic vein, so do you see any difference there? Anybody? Yeah. So the hepatic vein really does not have any wall. It does not. It's just a very hollow organ. Wall is not very prominent. Obviously, the flow is different to triphasic and so different flow in the hepatic vein and then monophasic portal vein. But that is one of the differentiation too. But that does not happen every time. Sometimes you can see the hyperechogenicity of the hepatic veins as well. Second is this is the mid-hepatic vein, but in 60, 70, even a higher percentage, left hepatic vein and the mid-hepatic vein, they may have a common origin. So that happens too. Okay.
Yeah, no, I think it's an incredibly important point, and remember Ken Chang mentioning it. Obviously, you identified this. So yeah, so differentiation between the wall, looking at the wall can help in differentiating portal and hepatic vein. Okay, so again, what we're doing is at this stage, you start to see the hepatic IVC. You may have to sort of withdraw the scope a few centimeter, 1, 2, 3 centimeter, and then at this stage, you should start to see the right hepatic vein coming out. So right hepatic vein tends to have a sort of quite broad lumen or caliber when it comes out, and it just tends to taper like a funnel, tends to taper away. But at this stage, so segment 8, which was underneath, has now come up. Okay, so 1, 4A, 8, now 8 has come up. So 1, 8, and 7. Going from this, segment 2 and 3, coming up, middle hepatic vein and the right hepatic vein. So certainly, this is right hepatic veins. In some cases, you may struggle, especially if there's a bit of hiatal hernia, which is why it goes back to the point that as soon as you've gone below the GOJ, you want to get some air in and make sure, is there a hiatal hernia or not? Because hiatal hernia is going to change your approach. Okay, so that's essentially all you need to do to see left, middle, and the right hepatic vein, and your left lobe examination is essentially done at this stage. Okay, left lobe. So, any question? So, as Dr. Hassan again yesterday said, so your plane changes. So initially we were scanning in this plane. Now we're going back, or we're pushing the scope in, and we've now gone under the liver. So the orientation is going to completely change. Okay. Sitting in the same plane, we can still examine the left lobe, but just to keep it simple, here we're going to focus on examining the right lobe. Now, examination of the right lobe is not straightforward in many cases. Okay. Therefore, this is going to take time. This is again like the similar examination of D2 when you're looking at the uncinate process. In some cases, this is almost as difficult because what we then have to do is we need to identify one of those three structures in the duodenal cap: portal vein, CBD, PD. Once you've identified portal vein is usually easy to identify because CBD in some cases may be completely, maybe of normal caliber, therefore it may not be seen, or with the pressure of the probe, it's compressed and you can't see it. But once you've seen the portal vein, what we then need to do is, you remember yesterday we talked about we going anti-clockwise toward the lever hilum. So the focus is again just trying to keep the uh, portal vein in the view as best as we can, and we want to see the portal vein actually dividing into the right and the left portal vein. So the left which is going away from the transducer and the right which is coming towards the transducer. Okay. So going anti-clockwise towards the liver hilum, looking for branching of the portal vein into the right and the left. So right toward the probe, left away from it. Again, with a further, in some cases, you may have to advance the scope a little at this stage. You should see this branching into it. In some cases, especially if there's any, either there's a ductal compression, dilatation, you may see a lot of intrabiliary radicals, some branches which may be prominent, and it may become tricky. But this happens very quickly, and then suddenly so many branches like appear, which can make it difficult. But if you can then see this dividing into anterior and the posterior, again anterior towards the probe and posterior away from it. So right, left, right towards the probe, and then when it starts to divide, anterior toward the probe, so right anterior, just remember it that way, right anterior, okay, coming toward the probe. And that just gives you a broad idea of where 5, 6, 7, 8 segments are. Okay, so this is again, we're talking mostly about pattern recognition. So get your eyes accustomed to this pattern recognition first, and then you can just try to, there are lots of pieces of the jigsaw here, and then you can start to put it together, how the portal vein branches are dividing into superior and inferior segments, how hepatic veins are dividing into the left, lateral, and medial segments. Okay, so far? Okay. We mentioned about looking at structures, right lobe, and gallbladder. Most of the time, the segments that is associated with the gallbladder is segment 4, and then the segment which is with the right kidney is segment 6. What is the clinical application of this? You see a lot of time commonly reported on the ultrasound report, focal fatty sparing. You will also see that when you're doing your EUS examination, you will see that clear differentiation in the parenchymal aquagenicity, the one which is sort of really close to the liver, especially those who've got a fatty liver. You see that focal fatty sparing. It's not a lesion and can sometimes be misreported on cross-sectional imaging as lesion when it's not. And again, with the right kidney, just broadly for the benefit of this discussion here, segment 6, because you're going to see, as Dr. Hassan yesterday said, when you've identified the aorta, you want to see two structures on the right, two on the left. You may or may not be able to see the right kidney, but if you start to seeing this liver, that may be the segment 6 of the liver. Right kidney may not be very obvious, but then you know that's where it is. And then obviously the IVC, aorta, and then CBD and PD. That is it, to be honest. So I think, as I said, the reason we want to focus more on looking at liver segmentations, pathologies, because there's a number of interventions that we may be able to and should be able to offer in the future. But we'll have to train our eyes to be able to sort of identify this pathology. Easier thing is, especially if a patient's had a scan, cross-section imaging, and if you are training with someone, don't look at the scan in terms of where the lesion is. Go and identify that lesion, then try to just make up your mind which segment it is, and then you can collaborate your findings with the cross-section imaging or CT finding or the MRI finding. Okay, I'll stop there. Any questions? Anything you guys want to ask? Correct. That's another beautiful way of seeing it. Of course. Just I'll leave it. I'll leave it. I'll leave it here. Yeah. अच्छा. Speak. जी. रेगुलर तैयार तो कर ली लेकिन उसको मसला है कि ये तो मैं थोड़ा बहुत करता हूँ ना वो तो करता नहीं हूँ. वो तो मैंने बताया था सिर्फ 2 केसेस किए थे साल में 3 केसेस किए थे. एक ही रेक्टल वायरसेस इंजेक्ट की थी. एक ड्रेन किया था. हाँ जी. नहीं नहीं और दूसरा दूसरा क्योंकि एमआरआई पे इतना ज़्यादा फोकस होता है ना. दूसरा but there's one situation where I use both scopes, radial and linear, and that's rectal, because I get my head confused.